This is Victor. Victor is your guys' rep. So both for Integra and Codman, we are both available to answer questions, help you troubleshoot. This is the limitor, and I know you guys are excited to have it. The main function of this as a lumbar drain, as a CSF drain in general, is to just restrict the amount of volume that is able to dump. This could fall on the floor, theoretically. And it wouldn't over drain, which is what we're trying to protect you against. So you have this, you guys have, I think you have the 20 ml model. You have both of them? Okay, perfect. So this is the 30 ml model. You can see the big giant 30. It works, there's a little float in here, and this float is on a hinge. And at the very top of that float is a little finger that sticks up and occludes this drainage section when it gets to that 30 mLs. So it just stops it. All that holds true as long as this is upright, in an upright position, and that's why we have the pole mount with it. Okay? When it comes out of the package, it comes in two separate pieces, and we periodically do education with the OR team to make sure that this little piece right here that attaches this whole system together doesn't get thrown away, because it comes in a little spare bag right here on the front, and not oftentimes, but sometimes that bag gets pulled off and then discarded. You still have this, it'll function as a drain, but you can't rely on it to limit the volume because it'll be laying down sideways, who knows what. So you got to make sure that this stays with the drain. The easiest way, and we tell the OR staff this all the time, easiest way to do it is just pull it out of the bag immediately, and right here in the back where this slot is, just snap it in there. Once you get it popped in there, it clicks and it won't come out unless you push that tab down and force it out manually, which is kind of difficult to do. Once you get that popped on, you just set it right here on top of that little post and crank down on that plastic knob until it's secure. Okay? It should line up. You'll see right here where it says pressure level, that lines up with your little yellow indicators right here when it is appropriately set on that pole. And then you have your patient side here. This little piece also says up, so there's a red up arrow on this. It just slides right into this slot. Let me do it without getting it too severely tangled. Right into that slot there, and there's another knob on top. You can turn it sideways so you guys can all see it. And you just tighten that one down. If we were monitoring pressure, this is where a pressure transducer would go, right here. Okay, and then this red cap is also where we prime the system. You definitely want to make sure that this is primed before it's attached to the patient. We do it aseptic technique per your policy and guidelines. What do we flush with? Sterile, preservative-free saline. So any of your sterile NS flushes that come in the 10 ml, those are preservative-free. If you're unsure, check the labeling, make sure it says no preservatives, okay? Preservatives are just toxic to the meninges, so they'll break them down if it was to flush into the system. The chance of that happening from the system is almost nil, but we always want to flush with sterile, normal saline that is preservative-free, okay? So you're going to take off this cap right here. You're going to go ahead and attach your syringe, and just very, very slowly, so that you get all of the air out, just start pushing your saline through. Keep an eye on this. Right now, this is actually clamped. It doesn't come out of the box like that. It comes open, so you should be able to flush. And as soon as you get a couple drips here at the end, and that tubing is completely free, you can change the position of your stopcock off to this patient line, and then flush up here until you get about 2 or 3 mLs in the bottom of this little chamber here. Once you're done with that, make sure you turn this off to the syringe before you disconnect the syringe. Because if that's still open, you take your syringe off, it's just going to start sucking air and you'll have to redo it. Okay? The reason why it's important, and then put your cap back on once you take it off, and or if you're using a transducer, you would do all of that flushing through the transducer to get the air out of that as well. Okay. The reason we want to get all the air out is because you can end up with an airlock, which will slow drainage. So your CSF literally won't drain, or it'll drain very, very slowly. And then you're calling your surgeon an hour later saying the patient hasn't put anything out. What do you want to do? So just make sure you get it all out. That 2 to 3 mLs that's in here, you can go ahead and open the stopcock, drain it into the bag. Try to keep this column right here full of fluid as well. It won't affect patient drainage, but it'll be hard to drain from here if that runs dry. So as you prime it, just consider that as part of the priming too. So you get that 3, 4, however many mLs in here. just open it real quick and then turn it off when you see that that chamber is empty, and just kind of leave a little bit of fluid in there. It'll make your life easier down the road. Again, the patients won't be with you that long, so it's not a huge deal. More of an issue in the ICU when you can't get that chamber to drain. It's a little annoying. But that is about it. Up here, you have this antimicrobial hydrophobic filter. So if this does fall on the ground or gets laid with the patient in bed, if it's clamped or something like that for transport, it's okay. This can get wet. As long as it doesn't stay saturated for 30 minutes, that vent will still work. This vent is what keeps the whole system draining because the air that's in here has to go somewhere. So as CSF fluid fills that, air vents out of that, okay? Changing the bag, also done aseptically. Highly doubt you guys will ever have to change a bag. If your patient drains that much while they're here in PACU, they've got other issues. But if you had to do it, aseptic technique again, follow your policy for cleaning all the hubs and stuff, changing your bag out. They are special bags, so they're different than the AccuDrain bags, your other CSF drain. They have these little holes that will snap on and make it a lot easier so that the load bearing happens on here and not on the actual burette.
If you find after the like at some point you go to empty it and you empty through that whole bottom section there, can you just reprime it through?
It's not necessary.
Then,
it's just it's one the next time you get some in there and you open it up and it's not draining out, if you just give it a little tap, it'll start to drain out. So it's not necessary. We just say it just to make your life easier. It's totally fine. It will still function perfectly fine. Adjusting the level right here, you have centimeters water and millimeters mercury. So whatever the physician's order is, that's what you're going to go based off of. And then again, your little yellow indicators here mark the level. So whatever you're going at. It's all gravity dependent. So the lower this is, the faster it'll drain. The higher it is, the more difficult it is for the patient to push CSF out. Okay. Leveling. So when you level to whatever anatomic marker the physician wants you to level per their orders, two different methods. Jenny said you guys do have some that have the laser level. Laser level is really easy. It's got the little bubble on top. You just push this button once to turn on the laser. Like they tell you in middle school, don't stare into the laser. And it'll shoot out a beam, and you just raise or lower this entire thing until it's at the appropriate mark. Tighten it down, and the laser turns off after 30 seconds. So you don't have to worry about it. It won't suck your battery. If you are using the line level, which comes in the kit, it snaps in right here. So right where your pressure transducer is, it snaps right in level like that. And you just hold your line level out, and you can either raise or lower your patient's bed or raise or lower this until it's in the right spot. Make sure it's nice and tight so it's not going anywhere on the pole. Make sure that this one is nice and tight. It's a good thing to check every time your patient comes in or you're doing handoff or something like that. Just check all of your knobs and make sure they're nice and tight so that the system doesn't go anywhere. Okay. Any other, CSF sampling, if it's ever to be done, again, per your policy and guidelines. You can sample several different sites. So where do you guys typically sample? You sample on the patient line or?
No.
So right here.
The nurses don't, yeah.
Okay, good. So sampling can be done right here. Again, make sure you clean the hub appropriately per your protocol and draw off there. Don't use needles on any of these ports. They're all needleless. So just a regular syringe, slip tip or lure lock is fine.
This would be the same technique as doing the EVD.
With the TNT and
Exactly. Yeah. Do you guys use DuraPrep? Okay. All right.
So our patients stay overnight in the RRU.
Sure.
Do you recommend that we get an extra bag?
Oh, like an extra bag.
Right.
The chances of them ever draining and filling this bag overnight is
nil. Okay.
Yeah. At any point in time, we only have 150 mLs of circulating CSF.
Okay.
We make between 15 and 30 every
Okay.
hour. So they'd have to be here for quite a long time to fill that up. But if you do want to keep an extra bag, a couple bags on hand, it's
Just in
not a
case
terrible
something
idea. You
happens.
can always get them from the OR or the ICU.
Okay.
It should be stocked in either one. We recommend changing one about 3/4 of the way full because it gets heavy, right? It's fluid filled. So you can do that again per your protocol and go from there. Transport with this, again, keep it upright whenever possible at all times, okay? Your patient can go to CT scan with this. This whole thing is MRI safe except for the pole and laser level, okay? So if your patient does have to go to MRI for whatever reason, you would just take this off, take this out. This little screw here is plastic, so that's perfectly fine. And it says on the back right here, it says MR. All right. So you just take this whole thing. Again, you would clamp per your protocol for transport, either lay it in the bed or, again, try to keep it upright. You could just prop it upright so that that filter stays nice and dry, and do your procedure. And then when you're safely out of MR, you would just snap this back on, clamp that down. Again, follow the little red arrows. We make it really easy. When I was in the Navy, we called this marine proof. You just label everything so you can't mess it up. Okay? No offense to any Marines.
Hey.
Just saying, that's just what we used to do. Okay.
Yeah.
You guys don't monitor pressure on these typically for the right. If you were going to, the most accurate measurement of lumbar pressure, or ICP if it's ventricular, is you turn off, to the drainage. So it's just going out to the transducer and getting patient information, right? And then you would open back up to drain. Again, don't forget that part. Check all your stopcocks troubleshooting. If you're not draining for whatever reason, first thing, check for kinks and check all your stopcocks. Make sure that everything is open, no obstructions. It is anti-kink tubing. I mean, you really have to. That would be kinked, right? But it's pretty difficult to do. There's a nice big green stripe on here so that nobody gets confused. This is not IV tubing. The ports here say CSF access on them, but just be mindful. Make sure that everyone is aware of what's going on. The red cap obviously says do not flush me. Anything to add?
I think just the big things from the organization side is just what resources you have available if you do have this patient. So our neuro guideline has a lumbar drain section. So typically, I think you're going to probably see more of like the neuro with the Limitor. But I know last time there was a little confusion. There is under the cardiac education, there's a little bit different setup for the lumbar drain we use there. So just remembering that differentiation, okay, that they're currently using an EVD type setup in the T-bar patients and the aneurysm patients over there. So
And hopefully we'll get that switched over.
we're going to meet with them, yes.